won't get into a car that's blue and black. I mean, there's sort of a, has this been actually been studied? Yeah. So there's a theory that the blue and the black looks to the colorblind fly like the stripes of the zebra, or perhaps that the zebra evolved. Why does the zebra have those stripes? It is the craziest damn thing. So maybe it has to do with avoiding sleeping sickness. There was a study recently where they took a zebra hide and ran across the savannah with this to see how many bites it got. It didn't actually pan out, is my recollection. The people of the Gambia, called the Fulani people, and in Senegal, you know, they wear that beautiful indigo, gorgeous clothing. And the indigo dye is very well prized because it's beautiful and hard to come by. And so some people hypothesize maybe that's why the flies love that color, because they're going after the indigo dye of the Fulani people. I don't believe that for a second, but having said so, it's been hypothesized. So yeah, if you travel in East Africa, please don't wear those colors. Any other questions about human African trypanosomiasis? Let's make a change. I'm going to do something a little different with you. Yeah. Trypanosoma cruzi. A little bit different. Remember I showed you this guy's journal? A British expatriate living in Brazil. And these were among a lovely, nice diary toward the time of his death. These are the highlights I picked out. So who was this? Some of you may not have actually read his stuff. But this is Darwin. We hypothesized that Darwin died of Chagas disease. Although we haven't proved it, I think we should. It would just be such a great thing to do. If you haven't read, so everyone's thinking about Origin of Species, which is an important book she wrote when suffering from this condition. Actually, this is a way better book. This is just his travel journal when he was a young 20-something-year-old botanist. Sort of a pointy-headed, bookish guy. He got into this tub and spent 5 years going around the planet. It's an amazing read. And so this is one of my favorite parts. March 26, 1835. At night, I experienced an attack, and it deserves no less of a name, of the benchuca, the great black bug of the pampas. It's most disgusting to feel soft wingless insects about an inch long crawling over one's body. Before sucking, they're quite thin, but afterwards they're round and bloated with blood, Darwin's blood. And in this state, they're easily squashed. They're found in part of Chile and Peru, and the one which I caught at Iquique was very empty. Now, being placed on a table, surrounded by people, if a finger, his finger, was presented, its sucker was withdrawn. The bold insect began to draw blood. It was curious to watch the change in size of the insect's body in less than 10 minutes. No pain was felt, and the meal kept it fat for 4 months, although after a fortnight or 2 weeks, it would feed again. Charles Darwin, March 26, 1835. From April 9th until I reached Valparaiso on April 17th, I was not very well. I saw nothing and admired nothing. We think that perhaps he was going through the acute phases of this particular infection. The bug that he described goes by many names. Barbero or Vinchuca, the cone bug, the reduvid bug, triatamine bug, my favorite, the kissing bug. All different terms for the same vector, the vector of American trypanosomiasis, which is called Chagas disease. The historical context for Chagas disease is a little bit different, and it's actually far more impressive. What Carlos Chagas did was to go into central Brazil at a time when it was so perilous for them to take the riches of the rainforest and send them by boat around the Horn that they decided to cut a rail line right through the middle of the rainforest to go straight down to Sao Paulo, which is very bold. And so many slaves and indentured servants died of a variety of things, syphilis and yellow fever, and this particular infection, which had never been described. So Chagas, whose own father had died, was raised by his uncle, who was a physician. He decided to become a doctor. He treated a lot of gonorrhea way back when, before good antibiotics, and he also figured out what was going on here. This is a new disease that he understood. And take a page out of his book. Ladies and gentlemen, if you make a discovery, for example, a new microorganism, what's the first thing you do? Aside from wash your hands, I mean. Name it after your mentor, right? So Oswaldo Cruz was his mentor. So if you want to get in good with your benefactor, name a bug after them. And this was very smart. And then the disease, of course, is named after Chagas, who's far more famous. What's up with T. cruzi? T. cruzi infection causes Chagas disease. Chagas disease is a huge issue. For our colleagues who live and work in Latin America, it is part of the fabric of their practice. It is very well understood. Here, north of the border, we have much less understanding of it, but we need to get savvy about it because it's a huge issue for us. So we think that there are millions of people who are infected in Latin America. In some areas, 1 out of 4 people may be at least strongly at risk of getting this particular infection. Now, if you take a satellite view of Latin America and focus in, I love doing that on Google Earth, where you can look in at villages and valleys. You know, prevalence and incidence data show that this is highly focal. You may have a village or a valley that's heavily parasitized. And one valley over, they can't seem to find this particular infection. It is local and focal. And that's both great for the people who live in the uninfected areas and a real challenge for those who are in heavily parasitized regions. I think the key is to say that the impact of this infection is tremendous. Sleeping sickness kills you 100% of the time. In Chagas disease, you have a different story. It's much more complex, and the immune interplay between the pathogen and the host is different. It may kill you right away, or it may linger and dwell and smolder for years or decades before causing trouble, or you may keep it under control and do just fine for all your natural-born days. It's a very difficult thing, but I want you to think about myocardial disease, congestive heart failure, GI disease, such as achalasia or dysmotility syndromes in these patients. It's not only the mortality, it's those disability-adjusted life years, right, the dailies. Then there's the qualities, right, the quality-adjusted life years. But these disability-adjusted life years in Latin America are so heavily impacted by Chagas because, let's face it, malaria is an awful thing. Many of you in the room have had it, I suspect, and that sucks. But you get over it. Either it kills you 1 time out of 300, or you get over it like everybody else. And then you go on about your business. But with Chagas, from the time you're infected, you may be unable to work or raise your kids or go to school, and that stays with you for all of your natural-born days. And that's where the economic impact seems to be so tremendous. We think of Chagas very much as a disease of rural Latin America and rural poverty in Latin America. The truth is, I think it has potential to come into favelas, into a more urban setting that hasn't really been described to my understanding. And I don't exactly know why that is, although I have some theories, and we'll talk about that. So we worry about this. These are the vectors. There's a variety of them. I think they're beautiful. This is actually, again, larger than life size, but they look sort of like a cockroach, except they have these beautiful striations and markings on them. What they all share is this incredibly scary-looking proboscis. Sometimes this is called the assassin bug, because it reaches out with its proboscis to try to stick itself into you and suck a meal of blood. And so, how do they find you? The way this seems to go is that they can smell us, sort of like the mosquito does, right? The mosquito can smell our body odor. We still don't know what they smell, by the way. They probably smell different chemicals coming off of different people. If you notice that some people get bitten all the time, mosquitoes, and not others, I'm one of the ones who doesn't get bitten. My daughter gets bitten every time. It's awful. So we think that with respect to these bugs, it's a similar story. And somebody's actually taken away their CO2 sensor. They still have a thermal sensor. So they will find you, and they'll find you when you sleep. And what they do, at least classically, is they will live in the ceiling and the walls of these very rudimentary huts or housing developments. The way the housing developments have gone classically, of course, is that there's a thatched roof, which is natural products, right? A lot of nooks and crannies, hidden, shadowy places for them to hide in the heat of the day, and that the walls are made of sticks, and the sticks are rammed full of adobe. And as the adobe gets there, it cracks and dries, and so there's cracks in the walls too. And if you do surveillance projects in these classical settings, you can just open up the walls and have these bugs right inside. Chagas himself went to, in his journal, he described the first few cases that he saw, young children. It is a pediatric disease primarily. And he did a surveillance study looking for bugs in the home of the first child that he saw, a young girl called Rita. And I think he found 1,400 of these bugs just in a 14 by 14 square foot hut. And the cat was heavily parasitized and dying, and this poor little girl was as well. So what's happening is that the bugs come out from their hiding places. They smell you, so they'll come down to your nose and your mouth. That's where the CO2 comes from. And that's why they get this reputation for being kissing bugs, because you can wake up with a hickey, like a swollen lip or something, like somebody's been smooching on you. What they're doing, of course, is taking your blood. It's a little bit different from the fly in Africa, right? The tsetse fly. With the tsetse fly, they bite you, and out of their saliva comes the infection. Chagas disease is so much more insulting because what's the old saying? If you're going to binge, you better purge. So what these guys do is they realize they're about to have a meal and they defecate on the patient. They want to purge their gut. So they poop on you, and then they start to take the meal. And in the stool, the feces of the bugs are the trypanosomes. And so in the night, as you sleep, it's not a painful bite, but it is a bit irritating. There is a little bit of an allergic reaction. After all, a bug is sucking your blood. And so people will scratch. or they will lick themselves, or they'll pick their nose. They will inadvertently, unconsciously inoculate themselves with the feces of the bug. Or the bug may just defecate right into your eye, or into your nose, or into your mouth. Yes, this happens. And that's how this infection gets propagated that way. So once these particular pathogens get into the system, they'll get into your subcutaneous or dermal space, and then they're taken up pretty quickly by the Langerhans cells, by the immune warrior cells of the skin. And that's it. Then it's all over but the crying. You are now infected with Chagas disease. And unlike what we talked about with respect to that very simple life cycle of African flavor, in the American version, it's an intracellular pathogen. So much tougher for the immune system to fight off, and so much more likely to be set up as a chronic infection. So, the majority of transmission is indeed vector-borne. We call that autochthonous transmission, but I call it vector-borne transmission. There's other ways to catch it. And in the United States of America, we're very worried about blood-borne transmission of Chagas. We'll talk about this a little bit more later. We now screen our blood supply for Chagas. That's new. That's since the year 2000. Prior to that, we would ask donors, are you infected with Chagas disease? Yes or no? And that didn't work out so well, right? In surveillance studies, we knew that about 1 out of every 10,000 units of packed red cells in America had Chagas disease in it, or at least was seropositive. So that was terrifying. And so we now have a much more aggressive policy around this.
In North America?
In the United States in particular.
Okay.
About 1 out of 10,000 American red blood cell packs was seropositive for Chagas. And that's pretty scary. The truth is, the pathogens themselves don't do well in the cold. And so if those red blood cells are kept at 4 degrees, or at 20 degrees, you kept them on ice for more than a couple of days, the bugs would probably die. But there is this whole new trend towards hot, fresh blood, right? The more senescent the red cells, the worse people do. Anyway, we're dealing with this now. But that's our problem. That's rare. What's common is the Latin American experience. And of course, similar to what we talked about with East African sleeping sickness, the same is true in Chagas disease. This is a zoonotic infection. When you go out and look at armadillos and opossums, they're all full of Chagas disease, right? They've all got Trypanosomiasis inside. And so no matter what we do, I think, with respect to prevention efforts, unless we torch the rainforest, which it occurs to me is still what we're doing, which is not a good policy, but unless we actually kill off every creepy, crawly, fuzzy critter, we're never going to fully be able to eradicate this infection. We call a cycle a sylvatic cycle if it happens in the forest. That's where the word sylvatic comes from. This is an infection of animals, and when people have gotten to the wrong place, we have become accidental hosts. That's how I would describe it. So what's the clinical presentation? We talked about different phases of African sleeping sickness. There's also different phases of American sleeping sickness. And so this is sort of analogous to what we talked about regarding the chancre. This is the chancre of Chagas disease. If it happens on the eye, it's called Romagna's sign, as Romagna described it. And it looks like she was socked by an abusive parent in the face or something. That's not what this is. This is her own immune response, an allergic reaction to the saliva and to the trypanosomes that are actually there at the inoculation. And there are these photographs here, laborers back in the 1800s, standing in front of their barracks where they were infected. They've got what looks to me like goiter. It looks like this huge engorged thyroid tissue. It's not thyroid tissue. That's lymphatic tissue. These are lymph nodes, anterior cervical nodes that are just packed with these pathogens. They are fighting off the infections as quickly as they pop up. So the acute disease in Chagas is very fast reticuloendothelial invasion of the pathogens into the reticuloendothelial system. And these are amastogotes. These are the kinds that don't have a flagellum. They don't need a flagellum at this point because they're already where they need to be, which is your lymph nodes and your lymphatic tissue, your own macrophages, your own monocytes. They're sitting there dividing and dividing and dividing. Eventually, they divide so much that they'll literally rupture that cell open, enter the circulation, and another bug may come along. The issue is that there's very little holding these guys back, and in spite of all that lymphatic response, yes, some patients early on will have infiltration of their bone marrow, myelosuppression, dissemination of this infection. And this can lead to pancytopenia. For reasons that I don't understand, not only do they like the macrophages, but they like nerve tissue. In particular, the autonomous nerves of your body. So they like the conduction system of the heart, and they also like the peristaltic tissue of the gut. In the case of the heart, it's a total catastrophe, right? Because you can have nervous tissue that's supposed to be busy conducting The SA node, you guys would have to tell me. Anyway, they're trying to make your heart beat, and instead they are inflamed. So what you end up with is a weakening of the heart muscle, difficulty with respect to inflammatory myocarditis, and in some cases, here's a nest full of parasites right inside the patient's heart muscle. Here's the autopsy of a young girl who died of fulminant myocarditis. You guys have to tell me, but I think that heart is big, right? Is it supposed to be the size of your fist? So this is a heart that's filling her entire chest cavity. And a tragedy, acute myocarditis very early on after that Riemannian sign was there. Intense parasitism. Actually, these parasites can go anywhere, but they love nervous tissue. And the immune response may or may not bring this under control. Intriguingly, about 1 out of 10 children infected this way will succumb. Now, what about those who survive? What's the natural history of this infection? It's interesting. The majority of people are fine, but about 1/3 will go on to have some form of chronic sequel, chronic Chagas disease, if you will. And those chronic diseases can lie dormant and quiescent for decades and then pop up in these two awful ways. Carditis, congestive heart failure, like we saw with Darwin, and then mega-organ syndrome, which I'll talk about presently. So with regard to myocarditis, I think what happens is that the parasites are in the myocardial cells. The myocardial cells send out a signal, I'm parasitized, please come and kill me. The immune system does that, and you end up with what is almost essentially an autoimmune myocarditis. This definitely leads to infarction, death of parts of the wall of the heart. In fact, one of the problems with this condition is that patients do develop aneurysms. Where the scar is there on the surface of the heart, you get an outpouching, outpocketing of the heart tissue. Dead meat doesn't beat, blood gets in there, it clots, and then these clots, of course, are high risk to embolize. This can lead to CVA, you can end up clotting off your kidneys, spleen, etc. There's also the issue around the electrical conduction system, like I mentioned. So dysrhythmias, even fatal arrhythmias, are well described here too. So here's a patient with cardiomegaly. I guess at a plain film you don't know if that's cardiomegaly or is it just a big effusion. It's not. It's not a pericardial effusion. That's a huge heart in someone who has no coronary artery disease. In fact, if you shoot their cores, what you'll see is that they have clean coronaries, but they have these global hypokinetic heart, biventricular failure, and thrombi sitting in these aneurysms that aren't there for any other known reason. That's what's shown here on this particular arteriogram. And so, biopsy the heart, you'll see the parasites that are there, and that gives you the answer, we're dealing with Chagas disease. Classical teaching was that the parasites were dead and gone, and that we were dealing with an autoimmune after remnant of this particular process. I think that's wrong. There is a trial called the Benefit Trial, which is a 10-year study from 2004 to 2014, so we're almost at the end of Benefit. I'm waiting to see the results of that trial. But the idea is that maybe these things are actually alive. Maybe they're metabolically active. Maybe they're actually eliciting an inflammatory response. Maybe we should give these guys antiparasitic drugs and see if we can help them. Early studies, going back to 2007 now, have shown that there may be a delay or reduction in your progression from NYHA heart failure class 2 to class 4 if you treat these patients. So this is being done in Latin America on a bigger scale, and I'm eager to see the results of that. But I would emphasize, that's for the heart. What about for the gut? So if you actually look in Auerbach's plexus, that's the peristaltic nerve tissue that's in your colon and your tubular GI, they're packed full of these parasites. Those nerves are also being killed by the immune system, and that means that peristalsis is reduced. When peristalsis is reduced, these organs will dilate up and become a huge problem. So here's an issue. This is an esophagram. Actually, it looks to me like a lower bowel barium swallow. That's an esophagus, which is unbelievably tortuously dilated. This is achalasia, and in fact, Chagas disease, the leading cause of achalasia in Latin America. At autopsy, this patient has died of mega-organ syndrome. Her small bowel looks like your colon, and the large bowel looks like a sea monster. And this big white thing, that's the urinary bladder. Remember, the bladder has a detrusor. It needs to squeeze when you urinate. The detrusor has been shot as well. And so you can imagine someone coping with this, all the gas, all the urinary retention, all the suffering that goes through these patients. So at a glance, it's complicated. We have early disease and late. And some people who go on to have early disease will be cured. Some will die. Some who have late disease will smolder and linger. Some will recrudesce. I would emphasize, don't get caught up in those details in the nomenclature. Please understand, when you have Chagas disease, you have risk, a lifetime, of the problem of this thing coming back decades down the line. So I like this picture. This is Chagas looking at his first patient. He's smoking a cigar, which is great. And he's thoughtful. And it's interesting, this young girl actually survived and was found late into life. In fact, she died in Brazil in her 90s and was still seropositive at the time that she passed away in the 1970s. It's a fascinating story. So he made her diagnosis by checking a blood film. What did I say about African disease? Check a blood film. Same's true here in Chagas. So although it's an intracellular pathogen, there is still that phase of the life cycle that's extracellular. That's how T. cruzi gets sucked up by the next kissing bug that comes along. Make a blood film. Cheap, easy, and a wonderful way to go. Unfortunately, the negative predictive value is poor. So if you have a negative blood film for Chagas, you may still be getting fooled. There's a variety of different testing platforms you can use to confirm your diagnosis. And I would emphasize that in my lab, at our hospital, we do PCR. If the serology is unconvincing, we're still worried about it. The truth is, in Latin America, they have a terrific system called xenodiagnosis. Right? What is xenodiagnosis? Sounds like something from Star Trek. So xeno meaning other or different. In xenodiagnosis, a child who is suspected of having acute disease is brought to the clinic. They take a Dixie cup with a piece of cheesecloth on top of it and a rubber band, and inside that cup is a farm, fresh, virgin, uninfected, wholesome, organic kissing bug. And they put the bug in the cup, and then they take the kid and they put the cup against the kid's leg or arm, and they leave it there for, what did Darwin say, about 20 minutes. And the kids are usually fine. Sometimes they don't like this very much, but usually they're distractible and easily fed upon. And then you take that cup and put it on a shelf, wait 2 weeks, and then cut it open, right? If you take that bug, slice it open, check its poop, and you see these pathogens, you know where they came from. They came from the kid. So we're using the bugs as cultured vessels. That's xenodiagnosis. Very cheap, pretty easy to do. The trick is making sure that the bugs are uninfected before they feed on the child, please. So quality control is important. But having said so, this is how things are often run in Latin America. So if you make a diagnosis of Chagas, what do? Yes, we have treatment. And boy, it really sucks. It is just such ineffective, problematic treatment. Although this is the New World cousin to African disease, different drugs are usually required. Nifurtimox is the one medicine that we use on both sides. And most children tolerate it poorly. A lot of GI issues and GI toxicity. But the idea is that if it's acute, we really want to treat them, although it's unreliable. Maybe 80% success. If you have a kid, recent infection, they can take their medications. 8 times out of 10 ain't bad. Although for the 20% who progress, it stinks. In chronic disease, it's much less clear that this is helpful. That's the benefit trial I was talking about. I'm optimistic this will show at least a modest benefit as well. I think what it really comes down to is how to deal with the GI achalasia. How do we deal with congestive heart failure? What do we actually do for these patients? So one drug, Nifurtimox, we talked about this before, that's the medicine we use in African disease in combination with eflornithine. With respect to this other medicine, benznidazole, again, goes back to the 1970s. It's a toxic, awful stuff. This is actually not available in the United States. In Latin America, it is still sometimes used because it's a bit cheaper, potentially, than Nifurtimox. In this country, I like posaconazole, an antifungal. Noxaphil, I think, is the name we use it in our yeast and mold-infected patients. Very expensive, only PO, only as a liquid, difficult to absorb. It's kind of like itraconazole. It's a real issue. But it shows the evolutionary similarity between fungi and these particular parasites. Not generally useful. I think when it comes to prevention, I would say, again, all about the vector. So what Chagas did and what we do today is the same. Going to these different sites, looking for the infections, rooting them out. It's all the same. Spraying for bugs, improving people's quality of life, improving their standard of living can have a huge benefit. And this actually works if we keep it up, if it's sustainable, right? So there are certain areas in the Southern Cone Initiative. Look at this, 96% reduction in Brazil, 99% reduction in Chile. They could not find a bug anywhere they went. If we stop these initiatives, there's no question that the bugs are still out there, the reservoir is still there. The price of success is vigilance. In the United States, we see this very rarely. I won't go through this. I think we are missing these cases generally. The seroprevalence rate in our domestic blood supply had been 1, I think I said 1 in 10,000. 1 in 35,000 is the proper number. That number has gone down because we're now screening these patients, initially with a questionnaire, now with serology. We see this. We see this a lot. Thank you for donating your blood. Here's a letter from your Department of Health, from the blood bank. You have a test that's positive for Chagas disease. Come to this clinic at this address for free screening and treatment. We will take care of you. And the return rate on these CDC-written, very kind, in Spanish letters, the return rate is something like 10%. The other 90% of these people are not coming to care because I think they just got a letter from the federal government and they're not fully documented. And this is the kindness and the sweat equity of these people coming to our country, running our economy, giving the blood from their body, and they're still nervous to come to care. It's a huge issue, and some of our colleagues at UCLA are very savvy about this, trying to link people to care in a non-threatening, supportive, cost-free environment. Without that, the infection will just continue to propagate vertically from mother to child. I had a case of HIV-associated Chagas disease we saw here at Denver Health back in 2000. I can show you her pictures in a moment, but the bottom line is HIV, a cellular immune problem, Chagas disease controlled by the cellular immune system. You put them together and it's a big bowl of bad. And this is a woman who died with Chagas disease in her brain. So she was a woman from Honduras, here she is, and she came in with diarrhea, leukopenia, cardiomegaly. She was diagnosed with HIV infection as a new problem because she presented with pneumocystis. She was treated, she was put on ART, and she did pretty well. But unfortunately, she became confused, developed neurologic decline, and ultimately needed not only a head CT scan, but also an MRI. And the MRI was very abnormal. And again, it's one of those you can read from the back of the room kind of findings, right? So she had midline shift, etc. It looked for all the world like PML or a primary CNS lymphoma in a patient with AIDS. Biopsied her brain, of course, it looked very different. So this particular specimen, she has both amastogotes inside an immune cell and also trypanosomiasis, just looking for the next bug to come along. Of course, she couldn't survive. So we're trying to deal with this by creating new drugs. Again, the lab of Wes Van Boris at Seattle is very interested in this area, and Fred Buckner too, and trying to figure out how this looks like Leishmania, which we'll talk about briefly in a moment, and how things are a little bit different. But I would emphasize that, in summary, T. cruzi is the agent of Chagas disease. You have an acute phase, which we talked about, but also a chronic phase. And that the chronic phase may either be mildly or slightly symptomatic or go on to fulminant congestive heart failure. You should make a diagnosis by looking at the blood smears, potentially doing biopsies, even xenodiagnosis in Latin America, which I think is a pretty slick trick. We treat these patients early, we have about an 8 out of 10 chance of having a huge impact on their quality and length of life. If we blow it and we don't treat them early, it's a problem. And even when we do treat, the treatments, of course, are very toxic. We prevent with control of the kissing bug, and I don't know whether we'll ever have an effective vaccine. I'm not aware of anyone really actively working on this area. Because it's an intracellular pathogen, it's complicated. And I wouldn't say that I'm hopeless about this idea. I think it would require a huge investment, time, effort, money. Meantime, if we just give people a better place to live, this disease should go away. And that's where most public health dollars are now being spent, I think for understood reasons. That's 2 out of 3 of the trips. We have one more trip to go, and if I'm not mistaken, we're scheduled for a lunch break at 12:30. And that lunch break goes for how long?
45 minutes.
For 45, okay. So we could go quickly through Leash. It'll probably mean that I keep you 5 minutes into your lunch break, but I'll pay it forward to you by giving you an extra 10 minutes of break. How do you feel about that? Nice. So let's go back to the third case. Hope that's okay with the course leader. Should ask about that. So we're back in Brazil. We're in Manaus. We're in the same place where Darwin got into trouble. But remember the picture that I showed you? It's not pretty, right? So this is the gentleman who has had this issue as a progressive erosive loss of his upper lip, also his soft palate, his cords, his upper airway. All are involved with this robust granulomatous destructive response. So this is Leishmania. Get manic about Leishmania. So in Leishmania, what we have is, I just wanted to distill this down into one slide so I can try to imprint this on your hippocampus. When you think about Leishmania, this is what I want you to think about, right? So I want you to think about the painless ulcer on the face of a grad student from CU living in Belize. I want you to think about a macrophage packed full of single-celled microorganisms. Think about the huge spleens on these young boys from Kenya. Think about this man losing his face and his life. I assure you, he'll die this way. And at the center of this big bowl of bad, the sandfly. Shown here, so blown up, that what you're supposed to be able to appreciate is that's the crease of somebody's thumb. Teeny, tiny little no-see-em biting phlebotomous sandflies. So how do we tie all this together? In Leishmaniasis, so who's treated a case of leash? Has anybody treated any leash before? You will. This is a common one. Unlike sleeping sickness, almost no matter where you practice in the tropics, leishmania is an issue. It's a global phenomenon. Not just Africa, not just Latin America, everywhere, including Oceania, and including Europe as well. And so what we have are hundreds of millions of people who we think are at risk. There are probably more than 10 million new infections, current infections, and every year, perhaps a couple million new infections per annum. Mostly in the tropics, mostly in Latin America, but also Africa and Oceania, and India as well. It comes in two broad flavors. So Leishmania has a skin form, that's cutaneous leishmaniasis, and it has a visceral or gut form, and that's visceral leishmaniasis. They're quite different. In visceral leishmaniasis, you have a progressive, fatal, if not treated infection. It is a killer problem. In cutaneous leishmaniasis, you have a big spectrum. Some people will just get a small spot. It ends up healing like a scar without treatment. No big deal. Other people have terrible progressive disease, awful disfiguring lesions, and potentially even loss, in some cases, of their palate and their nose and their mouth, as we've talked about. To make it even worse, when you combine leishmania with HIV infection, especially visceral leishmaniasis, it's a complete catastrophe. Those patients, they don't just die, they die quickly, and they die horribly. In effect, it's as though they have an incurable case of lymphoma. And this is a real issue for our colleagues who work in Europe, because the sandflies are totally happy to be anywhere in the Mediterranean. They love Italy, they go to Sicily, they have a great time, Greece, you name it. So it's not just an issue related to lack of access to care, although that's always the tragedy that we deal with. This is absolutely an issue in so-called developed countries as well. And in balance, that's probably a good thing, because it means the disease gets the attention that it deserves. It's transmitted by the bite of the fly, as I'll show you. The drugs that we use to treat this are very problematic. They are very toxic. They are very old school. They're very 2 centuries ago. It's a real problem. And the more we treat, the more resistance that we see. And we do not currently have a vaccine. So it's a happy story, right? Epidemiology, I love this slide because it looks like Larry King. Remember that guy Larry King used to have that thing behind him? The key is that the worldwide story of leishmaniasis looks like a lot of the diseases you'll look at in this course, like malaria. It's everywhere throughout the tropics. There are different subtypes, and as Pangea has pulled apart, and as people have migrated around the planet, different species of Leishmania have evolved to keep up. The main point is to say that there's so-called New World and Old World, meaning the Americas and everything else, and there's visceral and non-visceral, or cutaneous disease. I'll come back to this. So, this is the sandfly. There are many subspecies. These are the ones that bite. You do feel them bite, they hurt, and you can't even see what just got you. I used to call them biting gnats or no-see-ems. And it's a problem because they're hard to physically swat at if you can't see them coming towards you. But believe me, the female in particular really needs your blood because she needs to nourish the eggs that she's trying to grow. She needs that nitrogen. She needs the heme that's in your red blood cells. So they absolutely need to bite people or dogs or other vertebrates in order to pass on their own lineage. So the disease cycle is pretty straightforward. You're bitten by a fly. Out of the saliva of the fly comes the infectious form of this particular disease called Leishmania. Those cells of the infection, the amastogotes, end up getting inside your macrophages. When they hit the human macrophage, they are home. This is the evil of this particular disease. It's intracellular. They have evolved to live in the exact immune warrior cells that have evolved in us to fight infection. Right, so we all have Langerhans cells in our skin that keeps away the staph and the strep, and these guys are perfectly happy in there. They live inside a small vacuole, called a parasitophorous vacuole, and they divide and divide and divide until they finally explode and rupture out of the macrophage, get back into the bloodstream, into the circulation, and get taken up by another fly. That's the story of the life cycle of Leishmania. Not just in humans. I think if there's any one species I could eradicate, and I'm not going to alienate all you guys. I'm sure there's probably a lot of good dog lovers in the room. I hate dogs. But I just think about all the stuff they cause misery in terms of humans. And here's another example, right? Dogs that are mongrels, that are not kept and don't do anything good for the family, but they are heavily, heavily parasitized. They can't keep away from the flies. A terrific reservoir for Leishmaniasis. Tough to treat, tough to track down. Plus they also give you rabies, all kinds of other stuff. The bottom line is there's probably a great role for dogs in the household. They do good things. But this is one of the things they do that drives me absolutely crazy. So let's just do some cases with cutaneous leishmaniasis. Here's a student, an ecology student who's 21 years old. He worked in the jungle of Belize, and he comes home and has several months of this lesion. It looked like a pimple. He thought it was a zit on his face. He picked at it a little bit, and it got bigger and bigger. He's been putting antibiotic ointment onto it. He's used some Clearasil. Nothing seems to help. It is not painful. He's not toxic, and he doesn't have high fevers. So this would be a classic case of so-called New World cutaneous leishmaniasis. Here's another patient with L. brasiliensis group, one of the subgroups of cutaneous leishmaniasis in the Americas. What he's got, of course, is the obvious ulcer. He's also got this other secondary ulcer here, which is actually a little bit older. Excuse me, this one's a bit newer. It's actually started to crust over. If you were to palpate this man's forearm, you would feel other subcutaneous nodules there too. We call this sporotrichoid marsh. Have you ever seen sporotrichosis, the rose thorn infection you can get? It's a funny mold infection you get picking roses. So it looks like that, where you have along the lymphatics subcutaneous infection and these nodules, which in many cases come to the skin surface and rupture. And if you look at it close up, it looks like Mount St. Helens. It's got this big heaped up border and then an eroded center that looks to me like a pizza pie if you tear off the cheese. That sort of granulomatous appearance. Okay, and not particularly painful unless it gets a secondary strep or staph infection. Then they can actually hurt. Here's another example of this patient in Brazil, here on the side. Here's a patient who has this on the leg, and I talk about secondary infections or super infections. It's an issue. This is skin that's eroded and exposed to the world, and secondary infections are pretty common. I actually wasn't taught that. In London, they said these things don't get secondarily infected. That's bull. They absolutely do get secondarily infected, and that means that they're painful. And that's led a lot of doctors astray to say, well, it's a painful lesion. It can't be leishmaniasis. Wrong. You probably have strep on top of leash. There's a classical form of this called the chicleros ulcer. Chicleros are the people who go to the forest to take the chicle, the stuff that's in the chewing gum that you're chewing right now. That's a natural product, harvested from the rainforest, and they sort of cut into the bark of the trees and harvest this as a rubbery sap. And boy, the forest is where the flies like to be. They don't like to be disturbed in the middle of the day. It makes them very angry. And even if these guys cover up, it's hard for them to cover their ears. This is a destructive process where this guy is actually, it looks like somebody's taking a bite, very literally a bite out of his ear. There's not much meat to your ear, right? It's cartilage, skin, and a little blood, and so unfortunately he's actually lost the tip of his ear. Disfiguring, but not fatal. There's this one awful subcategory that I've shown you before that happens in some phases of New World cutaneous leishmaniasis. Those who are infected with the L. brasiliensis group, or the L. brasiliensis complex, may go on to develop this disease, which is a catastrophe, called mucocutaneous disease. Now, the taxonomists, the microbiologists, the people who actually sequence all these bugs, they've said, these are so different. This is such an awful thing. We're going to give these germs their own subgenus. We're going to call them Leishmania viania brasiliensis. So you'll see that L parentheses V parentheses brasiliensis. I just call them Leishmania brasiliensis, but technically speaking, if you see something called viania with the letter V, I'll show you how it's spelled. This is what they're talking about. And the reason, of course, that it's a disaster is not just for his social life. It's because it is a progressive problem related to the immune cells, the tonsillar tissue, and the lymphatics of the upper airway. So this actually started in his case after he was bitten. He had a cutaneous lesion that healed. And then, as happens in about 10% of cases, the lymphatics of the upper airway served as a happy home for this virus. In about 10% of cases, it will then progress, starting at the palate, moving up, forward, out through the nose, and then simultaneously down into the airways. And you can imagine how how he can actually take a breath isn't even clear. It's a complete catastrophe for these patients.
Can I ask a quick question?
Yeah, please.
Sorry, a couple slides back, there was a ulcer on his, one more, on the ankle. So is there anything physical that you would be able to identify that or suspect leash as opposed to just a pressure ulcer?
Yeah, so why is this just a pressure ulcer or something else? It's like everything else in trauma med. What is the history? So this is an active, young, employed person, so they haven't been bedbound. So there hasn't been a pressure source that you can identify. And if it's in Latin America in particular, and it's part of the body that's exposed to the flies, it's all that. It's thinking about what the local epidemiology is. On physical exam, there's not much going for this. The classical description is raised border that is not undermined. So if you could take a probe or your gloved finger and get underneath the skin edge, that would be a little bit different. Classically, you would be, if you're in Oceania, you'd say, oh, this is the Baruli ulcer, for example. But there's not much else that will do this. What if he just got a wound? He's working in the fields and he just whacked himself. Could it just be plain old strep or staph? Yeah, maybe so. He should have fever. He should be sick. He should have a leukocytosis. So the point of this was simply to say, although it has an irregular border, it doesn't have that classical appearance, this is still leash, in this case, secondarily infected because he's walking around in flip-flops exposed to it. But without the biopsy, which I'll show you how to do, you wouldn't know for sure. You wouldn't know. Your question. In the old world, it's confusing. We talk about wet versus dry lesions. This is called Leishmania major that's infecting someone, and it looks to me like a nickel allergy to your bracelet or something. It's not super specific. Unless you're thinking about the exposures, you might not actually make the diagnosis right away. Here's a girl in Syria who has a fascinating condition called L. recidivans, meaning a recurrent process with this infection. And what's happening here is that she's had the infection. They've actually injected the chemotherapy right into the lesion to try to kill it. She cannot get rid of it. It keeps coming back. In fact, it's now popping up in other parts of her body. There's something about her Th1 and Th2 switching that's wrong. This is not an HIV-infected child. She simply can't come to immune control of this particular infection. Sometimes patients show up like this. So this, I guess if I didn't know that this was somebody who was coming out of the tropics, I'd say it's lupus pernio, where you just get that big red bulbous nose. In fact, I'll show you a photograph in a moment that I took on Friday from our hospital in Seattle of someone who showed up with lupus pernio. They did a biopsy to confirm that it was vasculitis and packed full of amastogotes of Leishmaniasis. So the point of this is to say that it has many, many forms, many flavors. It's not just one appearance. And so please don't be fooled. If you're working in an endemic area, almost regardless of what you're seeing in the skin, especially in the age of HIV, which makes everything so interesting and so friggin' difficult, think about Leishmaniasis. The biopsy will give you the answer that you're looking for. So these are other nodular appearances. If I showed you this, that looks to me like a staphylococcal boil from somebody's brassiere strap or something. No, you made a biopsy, we've treated with antibiotics, it's not getting better. Think about Leishmaniasis. So that's cutaneous leash. When it comes to visceral leash, it's a little bit different. Visceral Leishmaniasis, here's a girl with L. infantum infection. This is a form that doesn't go to the skin, it goes to your spleen, it goes to your liver, it goes to your bone marrow. I think they do this because they have evolved to express heat shock proteins that can handle body temperature. Cutaneous leash, it needs a cool temperature. It just doesn't, in our lab, we can't grow them at body temperature. These guys are different. They absolutely thrive at your human body temperature, and they will feast on your very living innards and organs, and they will kill you. These are some boys in Kenya. This is a classic picture, certainly not mine. Somebody's taken a paintbrush and just outlined the spleens that they have palpated. Their spleens are chock-a-block full of Leishmaniasis. There is a condition called tropical malarial splenomegaly syndrome. It could look for all the world like this. These kids, however, do in fact have visceral leash. So in visceral leash, what you have is visceral, your so-called reticular endothelial system, liver, and especially spleen, and the bone marrow that are eventually replaced by Leishmania. They are eating you from the inside out. If you don't treat, these patients will die. And if you have HIV infection, it's a much more rapid and fulminant process. And until you fix the HIV, you will never be able to cure this. Even those patients in Africa in particular who get onto effective ART and get their CD4 counts back, they essentially have such a hard time coping with this particular infection. I want you to think about it like lymphoma. That's essentially what this is. It's an infection. Actually, I think all lymphoma is probably caused by an infection. That's a separate topic. Anyway, this is really behaving all for all almost like lymphoma. And to make it even more complicated, you can treat someone for their visceral disease and they can come back and get skin disease later. That's called post-Kala-Azar dermal leishmaniasis. Visceral leishmaniasis goes by this old-fashioned name called Kala-Azar, which is an Indian term for the dark sickness. For whatever reason, in India, they get darker skin when they're infected. I have no idea why this actually happens. And what this is a total mystery. This is the most florid example. This is much more typical. Looks like a molluscum or some other nondescript little lesion. No, it's actually Leishmania, someone who used to have a species that was in their spleen. And it's like it's just holding on for dear life. It doesn't want to let go. Treat them for visceral disease. They can still get this. Treat them for skin disease. You should be able to seal the deal. Now, very complex and very multivariate. So when you look this up in textbooks, I went to UpToDate the other day to look at this, you will see list after list of all the different species and subspecies, and it's sort of divided by Old World, New World, and the so-called Viania. That's the L. Braziliensis complex. Now, I boiled this down for you to be this table, and you have all these slides at your access. So I want you to think about Leishmania. Is it visceral? That's the Aldonamani complex. Is it Old World on the skin? It's those two. Is it New World on the skin? It's these. And is it mucocutaneous? And the key is that mucocutaneous disease is this subgroup. So if you are treating a patient who's been to Costa Rica, Ecuador, etc., they come back with Leishmania, you need to know what species that is, even if it's just on the skin. So if it's in that Viania Braziliensis complex, they need very aggressive treatment so they don't go on to develop that 1 in 10 chance of a mucocutaneous catastrophe. My buddy Joe Jarvis, who I teach with in Tanzania, said this is what you really need to know. Is it skin or gut? Is it Old World or New World? Is it Viania or not? And that's great. I love that. That's exactly how I want you to think about this. How do you make a diagnosis? I promise you we're almost done. You need to see these bugs. There's not a great serology for skin disease. In cutaneous leishmaniasis, that's the whole point. They really haven't exposed themselves to the full repertoire of your humoral immune system. They're stuck in your Langerhans cells. So you aren't making antibodies against these things, at least not much. So you really need to get a biopsy and see what you're talking about. If you're talking about someone who has visceral disease, you need a biopsy of their viscera, like their liver, or a lymph node, or their bone marrow, which is a terrific place to always do these biopsies. And once we actually grow them in the lab, we can figure out exactly what species we're talking about. We use that information to decide how to go. So here's our young guy, right, from Belize. If you want a biopsy for this person, guys, please do not go to the center of that ulcer. There's nothing there but granulomatous reactive tissue. You need the leading edge. That's where the critters are. So always go to that heaped up border. And if you do this, this is the picture we took on Friday. It projects pretty well. So here's everything you see. Every one of these things is an amastogote. That's the nucleus. That's the kinetoplastid. That's the membrane. So here's a macrophage from the patient's skin, and it is literally being torn open by all of these amastogotes coming out. It's the most strongly positive skin biopsy I've ever seen, just this last Friday. The same would be true with respect to doing visceral diagnostics. You'll read about the so-called splenic biopsies. You stick a needle in somebody's spleen and blow it out onto a slide. Great negative predictive value. I've seen so many bad outcomes with people who had a splenic rupture. I mean, spleens don't do well when they pop. So this has been developed in India, and the people who do it claim that it's very safe. I do not recommend that you stick needles or knives into people's spleens. It's a bad look when they bleed to death. You have a diagnosis where the patient died, that sort of thing. So the bone marrow, on the other hand, that's pretty safe, right? So I love going into some of these bone marrow. That's an easier way to go. Or even a lymph node. It's so good. And if you do this and actually take a look at the material, you'll actually have the answer there. So how do we treat? We treat these patients with chemotherapy. Think about it like cancer. The antibiotics that we use are very toxic. They're very tough to use. Pentavalent antimonies, so-called sodium stibogluconate. It's a heavy metal. It poisons them. They are like us. They're eukaryotes. What kills them also makes us sick. These patients get pancreatitis. They get terrible arthralgias and arthritis. And they feel pretty low. And it is an intravenous treatment, and it happens over 20 days. It's a real process. There's a drug called miltefosine, which is PO, and pretty well tolerated. For reasons that I cannot explain, in visceral disease, miltefosine works quite well on the Indian subcontinent. But in Africa, in Latin America, in the rest of Oceania, much less reliable. And I think this is because the species that we think are the same must be subspecies that react differently. Some people feel differently. They'll say, no, there's something about the Th1, Th2, or the so-called HLA makeup of the Indian population, the human host, that's different from the African host. Maybe. It's not clear, but what we do know is that oral miltefosine does not work in Africa. So where I teach and practice, we're stuck doing much more toxic treatment. Ambisome, liposomal amphotericin. This is a very reliable way to go if the patient's HIV is under control. It's expensive in my country. We spend $1 billion a year in the hospital on that one drug alone. In Africa, they get it profoundly cheaper. And I don't know how they do this exactly, but it's kind of exciting. You still need to get hooked up to IVs. You still need to go to the hospital. It's still a barrier to care. Prevention is exactly what you would expect. Stop those flies. And those flies are just teeny tiny. There's a lot of mosquito nets. They'll fly right through them. And so it's a huge, huge issue. I think we should kill all the stray dogs in the world, but that's my own personal thing. You guys can yell at me about that later. So reservoirs, vector control, public education, and again, improving the quality of life for these individuals. So that's an incredibly complex topic over a period of about 20 minutes. Yeah, I burned my bridges with you guys. I'm sorry. Those key concepts, think about those sandflies. Think about this happening anywhere throughout the tropics. It is an intracellular pathogen in the patient's immune cells. And making a biopsy diagnosis is really what you need. I would not rely on serology for this particular case. Treatment will be tough. It sounds like by show of hands, none of you has treated leash yet. You will. This year, and work with your friends from ID to get patients through. They can make it. I think if you're dealing with a traveler, everything's going to be okay. When you work in country, and it's a huge, massive problem, working with these children and their families and their parents, it's a whole different kettle of fish. So we are, and I've also given you, by the way, a little table here, which is sort of a summary of everything we talked about, for all the different tri-trips that you can review for your examination study purposes. So let's do lunch break. How long do you think we can or should do?
I think what we, if it's all right with you, Paul, what we could do is we could give you till 1:30, which is giving you back so you have a little bit more than 45 minutes for lunch. And then we'll make up the time by decreasing some of the break time, 5 minutes or...
Or I'll cut a case. Wherever it's easy.
Yeah.
Breaks are good.
So, is that all right? 1:30, back here for lunch.